Support for UWTV is provided by the Boeing Employees Credit Union.
Hello and welcome to Talk Medicine. I'm Dr. Peter Neligan. I'm the Director for the Center for Reconstructive Surgery at the University of Washington Medical Center, and with me in the studio is one of my partners, Dr. Otway Louie. Today we're going to be talking about what we do, which is reconstructive surgery, mostly related to cancer reconstruction. And we're going to be specific a little later in the program and talk a bit more about breast reconstruction. We do a large volume of breast reconstruction at the University of Washington Medical Center. Apart from you and me, Otway, we have two other partners, David Mathis and Hakeem Saeed. And I guess we should explain to the viewers that we are plastic surgeons, and people often get confused about what is plastic surgery and where does reconstructive surgery fit in and where does aesthetic surgery fit in.
Yep. So, I mean, plastic surgery can be divided roughly into two main categories. One is cosmetic and one is reconstructive, but oftentimes there's a lot of overlap between the two, and the distinction is actually not absolute, and there's some grades involved. But when you talk about reconstructive surgery, you can break it down by site. There's head and neck reconstruction, trunk body reconstruction, and lower extremity reconstruction. We really do all sorts of reconstruction here at our center.
Right. And we also don't leave our aesthetic surgery behind fully, because our reconstructions are designed not only to close a given defect, but also to make the patient look normal and natural and to restore form and function.
Right, and I think a prime example of that would be our work with the facial nerve paralysis patients, because in those cases what we're doing is trying to restore both their aesthetics, in that you want a patient to be able to have a natural smile, but also function as well.
Right. And that's one of the things that we do a lot at the center is microsurgery, which is essentially transferring a piece of tissue from one part of the body to another with its blood supply and maybe its nerve supply, and then hooking that blood supply to blood vessels in the area that we're reconstructing.
Right, and you can do it in the head and neck with the facial nerve paralysis, bringing muscle from the thigh up to the face and hooking up the blood vessels and nerves. And you can do it with breast reconstruction, moving skin and fat from one portion of the body up to another portion of the body.
What do you think makes us different from other centers, or are we any different from other centers?
I think there are certain things that distinguish us from other programs. One is the group of guys that you've got assembled here is absolutely wonderful coming to work, because it's a very collegial atmosphere. I think
yeah, we all like each other.
We do, and I think that actually helps. And we all help each other too.
Right.
In some of these long cases, it's basically very valuable to have someone that you can come in and help out with, because you can shorten the operative times and the amount of anesthesia that patients have. But I think the second thing that really distinguishes us is the high volume of cases that we see here. The amount of micro cases here is huge. I mean, we're doing up to 6 to 8 cases a week sometimes, which is probably more than your average even academic center out there doing micro.
Do you think that makes it safer for patients?
Yeah, I think studies have shown that high volume specialized centers have better outcomes than places that do it few and far between.
Right. I guess one of the other advantages you already mentioned is the fact that we often work together. So if we have a long case, two of us will often scrub in on that case, particularly for some of the breast cases that we'll talk about in a minute.
Right, and when you have two surgeons helping out on a case, you can shorten the duration of these cases significantly, and risks of anesthesia as well.
And the reason the surgery takes so long is because the microsurgery part is done under an operating microscope. So it takes a long time. It's fiddly and fussy type of surgery.
Yeah, and that's why it's called microsurgery. It's because we are operating underneath the microscope and hooking up blood vessels and nerves underneath the microscope. And you have to prepare both the vessels that you're hooking up into as well as the vessels that you're moving. And all that takes time, and we have to be very meticulous about it.
I guess what we're going to talk about more specifically today is breast reconstruction, and we offer the full gamut really of breast reconstruction, including implant reconstruction as well as tissue reconstruction.
Right, and whenever we meet with patients, we'll talk to them about the full range of options, including expander and implant reconstruction, as well as using their own tissues.
A lot of people watching may not know what expanders are, so we should probably explain that these are temporary implants that are put in, and they're inflatable so that we can actually stretch the tissue so that it'll accommodate an implant and have the new breast looking like a breast and not just like a lump on the chest.
Right, because what happens after mastectomy is you're basically short on some skin as well as the breast tissue, and the expander is basically like an inflatable balloon that has a little port where you can inject saline into that will stretch the skin out gradually so that you can put an implant or your own tissue in there afterwards.
And often when we use the patient's own tissue, then we can avoid the use of the implants and just have them use their own tissue.
Right, and having them use their own tissues is beneficial also because of the fact that although it's a longer and more complex surgery initially, down the road there's less to worry about in terms of potential complications of, let's say, with implants. When you're talking about having implants in a foreign body within your body, you can run into problems and need reoperations down the road to fix those complications.
Yeah, one of our partners, Hakeem, always tells patients that the implant surgery is surgery for life, because they're going to require further surgery to adjust the implants or you know, take care of scar tissue or whatever. Whereas tissue-based surgery is a one-shot deal, even though it's a bigger operation up front. They're not going to require further surgery down the road.
Right. You get it done initially.
Right. One of the other things that we can offer is immediate breast reconstruction, and that has some big advantages, I think.
I think, yeah, immediate reconstruction, I think one of its biggest advantages is that you're preserving your breast's natural skin envelope, and so you preserve the shape and the size of your breast, versus a delayed reconstruction where patient has the mastectomy and remove all the breast tissue and all the skin shrinks down. You're relatively short on skin, and you have to kind of recreate that skin, either using skin from somewhere else or stretching it out with an expander. But it's very hard to duplicate the shape of the native breast.
Right. But we can still get a pretty reasonable, in fact a nice reconstruction in a delayed reconstruction, even though I think we both agree that an immediate reconstruction is probably the nicest if the patient has that option.
Right.
One of the reasons I think a lot of centers can't offer immediate reconstruction is because of the problem with scheduling a breast oncologic surgeon and a plastic surgeon to do the mastectomy and the reconstruction at the same time.
Right, and that's one of the benefits of a center like ours, where you have 4 full-time plastic and reconstructive surgeons that will actually be available to do the case probably much sooner than at some other places where they don't have the manpower to do that.
Right. These cases take a long time, which is why the scheduling is so difficult to arrange. And not every patient has the option for immediate reconstruction.
Right. And those patients that are known to be requiring irradiation, in those patients we would actually recommend delaying the autologous reconstruction or using your own tissues for the reconstruction until after they've received the irradiation. When you do irradiate your own tissues, they tend to shrink and scar down. So you don't want to move tissue from one place in the body to the other place and then have it irradiate it and then have it shrink down and contract it. So in those patients, we recommend getting a reconstruction, a delayed reconstruction.
Right. Because otherwise you can convert what was a perfectly nice reconstruction into something that is distorted and difficult to fix also.
Exactly.
But if patient has had radiation, we can still go ahead afterwards and do the tissue reconstruction. In fact, we'll often recommend that rather than implant reconstruction because of the increased complications that you get with implants in patients who've been radiated.
Right. Both the aesthetic result after radiation with implants is suboptimal compared to if you weren't irradiating the breast. Certainly, the risk of complications with a tissue expander and trying to stretch your radiated skin is also much higher.
I think the audience would probably be interested in kind of the sequence of reconstruction, and also we should maybe talk a little bit about the other breast in patients who are just having a single mastectomy.
Right. So when we talk with patients, the breast reconstruction is a staged process, and the first process is, when you're talking about using your own tissues, is to bring that tissue from wherever site you're moving it to up to the chest to reconstruct the breast. And a second stage is when we can fine-tune and kind of shape the tissue that we've moved up there into a more natural breast shape. We tend to take more tissue than we need and move it up there because we can shape the breast later in a second stage to kind of a more natural looking appearance.
Right. And the way that we do the reconstruction is a little bit different from most centers too, because we do the standard reconstruction with tissue is called a tram flap. And that's a piece of tissue from the abdomen that is attached to one of the muscles of the abdomen and is then swung up into the chest to create the breast mount. And in doing so, you weaken the abdominal wall fairly significantly, whereas the technique we use is a bit different.
Right. The technique we use is called DIEP, or Deep Inferior Epigastric Perforator Flap. In that case, what we're doing is dissecting the blood vessels out underneath the muscle and its branches that go through the muscle and the skin and fat above it. And the goal is to leave that muscle behind. And when you leave that muscle behind, you cut down on the risks of weakening the abdominal wall. And in doing so, you help prevent any hernias or bulges forming, which was a problem with the historical pedicle tram flaps.
Yeah. What we try and do is to create the breast mount at the first operation, match it as much as possible to the other breast, but we have another chance to correct that when we do the nipple reconstruction, which we do a couple of months later.
Right, a couple of months later, and we'll be showing a little clip on nipple reconstruction later. The nipple reconstruction can be done in clinic and under local anesthesia. But there are multiple opportunities to kind of fine-tune and shape things. And
oftentimes you'll have to adjust the remaining breast. If it's particularly large or particularly droopy, then the patient may need a breast lift or a breast reduction or some sort of adjustment to that side in order to match to the reconstructed side.
And it's, again, that's the junction between reconstructive and aesthetic surgery.
Right. And the nipple reconstruction itself is in a couple of stages too, because again, the first stage is just to create a protrusion that looks like a nipple, and then the patient comes back for tattooing secondarily to put pigment in to match the other side, or in bilateral cases just to put pigment in, and they end up looking pretty natural.
Yeah, they look very natural, but it is a stage process, so all told a patient will be undergoing 3 to 4 procedures over a course of a year.
And as those procedures progress, they become more and more minor, because the first one is the big one, and then the second operation where we're doing the nipple and the adjustment is less of a big procedure. And tattooing itself is just an outpatient clinic procedure. So I hope we've given the audience a good idea of what breast reconstruction is about and the steps involved. And I think we're going to meet with one of your patients and discuss it some more.
So today we're actually fortunate to have one of our patients, Ms. Cindy Perry, who actually underwent the procedure called the DIEP flap. Thanks so much for coming today.
Oh, I'm very happy to come.
So why don't we talk about a little bit of what led up to you getting diagnosed with breast cancer and meeting the breast surgeons?
Yeah, so I went in last fall for my screening mammogram, and then I received a letter calling me to come back in for some additional views. And since that had never happened to me before, I was a little anxious, and then I also had to go to Seattle Cancer Care Alliance for the mammogram views instead of where I normally go.
That must have added a little bit to your anxiety.
Yes, it does, because you go to a cancer center and already reminded what a mammogram is all about.
Right.
And it was there when I had the additional views that I was told that the imaging indicated a high likelihood of breast cancer. And then I went back to Seattle Cancer Care Alliance and had a biopsy done mammogram guided, so I was in the mammogram, and it was the results of that biopsy indicated I had breast cancer.
So was that because there was no lump to feel that they had to do the mammogram guided biopsy?
Yes, actually, because it was what they saw was microscopic, and so there was no lump to feel or see. It was more what they call microcalcifications was all they had to indicate that there was some cancer there. So that's why they did it that way, yes.
So what were your thoughts when you were first diagnosed with breast cancer? That's must be pretty shocking.
Yes, I was stunned. Again, it's just nothing. You go in every year for your mammogram, but you don't really ever expect or hope for anything but it just to be normal. Right. So yeah, I was stunned. I was just taken aback. I just didn't really think, again, being younger that I am, that was something that was going to happen to me at this point in time.
So then how were your treatment options presented to you? What was the sequence of that?
Yeah, so I went to the Seattle Cancer Care Alliance, and there I met with the oncology surgeon, the oncologist, and then the radiation oncologist, and they sort of laid out the option for me, since I had early stage breast cancer, was I could have a lumpectomy, or in this case, sort of removed a section of the breast, and then radiation treatment. You know, or I could have opted for a mastectomy at that point in time. And then I opted for the lumpectomy, so I proceeded with that, which occurred in the end of December. And then, unfortunately, that procedure did not remove all of the cancer that was in the breast.
That must have been a bit devastating when you discovered that.
Yes, it was very devastating, because I had really just thought, okay, I'm going to have this procedure, and then I'm going to proceed on. And then when that didn't happen, you're like, well, wait.
Yeah.
And then at that time, when I went in to talk to the oncology surgeon, he then gave the option of, well, you can have a mastectomy, or we could try another surgery to see if we could get all of the cancer on a second round. And I think then, learning, wow, a mastectomy, I might be facing that. Again, it was pretty, it's just pretty devastating, yeah. Hard to hear. You just, and I thought, what? I thought I had early stage cancer. Why am I going to have
right.
that as a possibility?
So you opted for the re-excision first, or?
Yes, I did. I did opt to try that again, and unfortunately, that didn't do it. There was still cancer remaining after the second re-excision.
So once that re-excision came back positive, it became kind of clear that you would need a mastectomy and removal of the breast.
Yes, it did at that point, and again, that was a devastating moment to realize that that was going to happen. And then I was actually relieved that it took 3 weeks from that appointment with the oncology surgeon to schedule the procedure, because it did involve him
to do the mastectomy.
The mastectomy, yes. And then you to do the reconstruction and to coordinate those schedules.
Right.
I was pretty impressed with that time frame.
So when he recommended mastectomy is when he actually also referred you to us so that we could discuss the options available to you for reconstruction, which was what we would be doing.
Yes. Yes.
And just tell us a little bit about your thought processes in terms of the different options, your own tissues versus implants, and which way, you know, what kind of factored into you choosing the DIUP flap?
Yeah, so from our discussion and looking into it before I came into my appointment, I opted for the DIEP because, one, with the implant surgery, it's my understanding that there can be subsequent surgeries over time, either replacing the implant, or there's scarring or shifts in place, or any number of reasons.
And that's almost inevitable with implants.
Yeah, yeah. And I just, that was worrisome. I didn't want to have to face, you know, repeated surgeries over my lifetime.
Sure.
And then the other thing I liked was the idea of it being my own tissue, and rather than, you know, a foreign implant. Somehow that made it feel more like it was going to be more natural, a part of me, and more like my breast. And to me that was important. And then I felt fortunate I had the option to have that procedure.
Were you worried about the extent of the operation? In fact, it was going to take several hours to do, and
yes, I was. I was worried about it, and luckily you let me connected me up with two of your previous patients who had had the surgery. One was 6 weeks from her surgery, and one was 6 months from her surgery.
And how did that go, the discussions with them?
That went well. I mean, I talked to them both on the phone. They were very happy to talk to me, and they described their experience with the surgery and how they recovered and how they were doing at their points in time from the surgery.
And they can tell you things that we just don't know because we haven't experienced it.
Yes, and that's what was really, I felt very glad that that was opportunity was given to me, because we were able to also discuss emotional aspects of it. You know, what does it feel like? And, you know, because there's so much, I think we place on the female breast, you know,
right.
from so many emotions and other things that go into that
well,
part
I guess
of the
also
body.
it's a scary thing because you can die from breast cancer, and it's a
Yes.
realization that that can happen too, obviously, which nobody wants to think about. It must be helpful to talk to others who've been through that.
Yes, it is helpful because, yeah, that is always in the back of your mind. And, you know, and part of what you're thinking is, well, this breast could kill me.
Right.
I need to get it out. But then again, there's the conflict of, but, you know, it's a part of me. And so, yes, in that way, talking through those feelings with the women who both had similar thinking as I did about, you know, you want that part that could kill you gone, but then it's just an important part of you that.
Yeah.
So how was the day of surgery? Was that obviously it was a stressful day, but can you
Yes.
tell us a little bit about it?
Yeah, so we arrived there early. I think we had to get there at like 6, and then we went back to an area where you're, you know, in like a hospital bed waiting to go to the operating room. And my husband was able to sit there with me. My parents were out in the waiting room. They had come in from Chicago to be here for the week. So that was really nice that my husband could be there. And I think we just tried to talk, and then we tried to relax and meditate a little and just tried to be as calm as we could.
And just get prepared for the surgery itself.
Yeah, and just sort of get prepared for it. Again, I had done a lot of the emotional preparation, I guess you would call it, over the few weeks. It was a 3-week time period between when I knew I had to have the mastectomy and the surgery was scheduled, and I think I went through a lot of that process during those 3 weeks.
So I guess the next thing you remember is waking up in the recovery room.
Yes, and then in the recovery room, again, what was nice is that your family or friends can come in, and so my husband and my parents were able to come in and just talk to me for a few minutes, and then that's reassuring because I was pretty confused and disoriented, and you know, to me that amount of
Just
time didn't pass,
yeah.
and you're groggy, and
Yeah.
you're feeling pain, and you're in an unfamiliar location, and so it was really nice to have the family members be able to come in and visit with me.
Yeah, you certainly have a very supportive husband who's
Yes.
always at your side, so it's a nice thing.
Yes, I feel very blessed.
Tell us a little bit more about the following days. So you had your surgery, you wake up, you're in the ICU, and you're obviously in some discomfort, and now you're trying to start getting up and moving around the day after and the 2 days after surgery. How'd that go?
Yeah, so I was in the intensive care unit for the first day and a half, and while they monitor the blood flow in the breast.
It's just not that you're deathly sick, it's just that we need to be able to monitor the blood flow. And it's the best place to do it.
Yeah, because they check it every hour, and that's my understanding only where you can get that level intensity of nursing care.
Right.
And then I think, yeah, it was the second day from surgery. I stood up. Well, actually, you can't stand up because so much tissue is gone from your abdomen that you're bent over. You just can't stand up. You're just not able to because it's just too much. There's not enough stretch. So that's kind of awkward, and then certainly you wonder, wow, how long is this going to be? And it's a little disconcerting. But again, since I had talked to the previous 2 women, they both told me it took about 2 weeks before they were able to stand up straight. And I would say that's about what was for me. After about 2 weeks, I was able to do that.
So what about pain? Was it more painful than you expected, or less, or
you know, actually there was less pain than I expected. I just envisioned a lot of pain, and certainly I had pain medication in the hospital and when I first went home, but it was much less than I thought, and most of it was really in the abdominal area, very little pain in the breast.
I think that's what most patients find, is that it's less than they anticipated, but it's not pain-free, but it's
Right.
less than they anticipated.
So you left the hospital after about 4 or 5 days,
Yes,
and now you're about 4 weeks out.
yes.
What are some of the activities that you're able to do now compared to like 4 weeks ago?
Yeah, so now I have been able to go on long walks. I am actually a physically active person in general, so I've been trying to go on 2 30 to 45-minute walks, you know, in the morning and then in the evening. And I guess that feels, at first I could only go, you know, like a few blocks, and I've gradually built up to that over the 2 weeks since I've been able to stand up straight. And that feels really good, that I'm returning to my functioning that I was at before. I feel I have more energy, I'm more alert, and I'm surprised how well I feel after 4 weeks,
Right.
that I do almost feel close to normal. I was not expecting that.
So I guess you still haven't had your nipple reconstruction, and we actually have a little animation to show the audience how we do that.
Yes, that's correct. I have not had that yet since it's just been 4 weeks. So yeah, it'd be interesting to see that animation.
So maybe we'll look at that now. So this is the flap of tissue that we raise on the breast, and it's just simply folded and sewn to itself just to produce a prominence, and the area that we take it from is just simply stitched closed, just leaves a line and then a bump that looks like a nipple. And then the next stage after that will be the tattooing, which leaves you with a fairly natural looking nipple usually.
Yeah, and again, from the pictures I saw, and the one woman who was 6 months out did say it was very natural looking. They were impressed at how much it really did look like their other breast.
And sometimes we need to touch up the tattooing because it tends to fade over time, and also in the scarred area where the nipple has been harvested from, the pigment sometimes doesn't take as well on the scar as on the natural, on the non-scarred skin, so it sometimes needs to be redone, but it's a very simple procedure.
Both those procedures are actually much smaller than the procedure that you've already gone through. You've been through the tough part.
Yes, and so I again, I'm amazed at how I feel at 4 weeks, so it's really been a great experience for me.
Cindy, thank you so much for coming in and sharing your experiences with us this afternoon.
I was happy to.
Thank you very much, and thank you all for watching this edition of Talk Medicine.